Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 125. This seems to be a season of controversies regarding interventional cardiology. I'm just returning from the American Heart Association's meeting in Philadelphia, and there is raging controversy with Courage 2, or call it ischemia, whatever you want. But this morning we are going to address the previous issues, many areas of contention there regarding the Excel trial, and we have two absolute world experts joining us. I'll have Dr. Sharma introduce both of them and lead you through the discussions. And also, if you notice, we have posted just this morning on the website, we have replaced the case with something which is, I think, it's going to be challenging, very relevant to our discussions, and I'll have Dr. Kinney take us through to that. So, Samin, I'm seeing the guests behind you. Go ahead and introduce them.
Well, of course, the welcome to our CCC live viewers globally, and have a very fortunate today, myself and Dr. Kinney, to host two stalwarts in this field of controversy, I would say, because it has raised, some people may say there may not be any controversy, but a lot of discussion about the Excel 5-year data, and of course, as you mentioned, with the ischemia, which will focus next month. And of course, a lot has been already coverage, our media coverage here at Sinai about ischemia. But key is that now we have two great experts in the field, and particularly one who conducted the trial, and Greg Stone, who is the Director Chief, our Academic Officer for Mount Sinai Health System. And Greg, welcome.
Thank you.
And Dr. John Puskar, who is the Director of Cardiothoracic Surgery and Director of Surgical Revascularization for Mount Sinai Health System. So John,
thank you.
Welcome here. So purpose was that what could be the most appropriate discussion point than the left main. So we did have a left main, which we announced e-blast last Friday, but then Annu had a very good case yesterday, relevant, and which was sent this morning. So with that note, maybe we just go through the quick angiogram, and then we'll have a lot of discussion later on. So this is the patient. Actually, if you see the angiogram point of view, we replaced this case because it's a true, very significant calcific left main disease, let me just go through our slide set. We can show the slides. These are our usual the disclosures, and so this is a 77-year-old male, has some risk factors of hypertension, high lipidemia, and has mild class 2 angina and dyspnea on exertion, and has little TIA type of loss of memory symptoms, which led to the carotid duplex. No new crescendo angina or so, but as a stable, on the background of stable angina, had the ultrasound, which revealed significant bilateral disease, more significant, 95%, calcific ulcerated left internal carotid, right about 60%, and the plan was to do carotid and arterectomy. And knowing the patient has angina, they skipped the stress test, and patient came for the cath yesterday. So, I mean, this is a patient also has known aortic stenosis of EF of about between 2 studies, 50 to 60%, valve area 1.2, and has in good medication. So this is a case which we showed the calcific left main right from the beginning, moderate disease of the LAD. There are some disease in the circumflex branches, which Annu will show in other view, and the diffuse right coronary artery. If we can show the angio, yeah.
Yeah, I think a moderate disease in the circ, I would say nothing significant, but definitely if you see here, significant RCA disease from the ostium, calcific ostium and proximal to mid RCA, and significant disease in the distal RCA just at the level of the crux, dominant RCA, and then this is the left main in the cranial view. So we were debating what is the proximal LAD. I think imaging probably would help us here to understand exactly what is the disease at the level in the proximal LAD, just at the level of the diag and the septal.
So, John, your point of view, from surgical point of view, knowing that the heavily calcium is only in the proximal segment, distal vessel seems to be not much calcified, so from surgical point of view, it's not an issue.
No, this looks like a very good target for an internal mammary to the LED and perhaps a radial artery to the PDA.
Yeah, we can go to the RCA also. RCA actually is quite, even distal quite calcified. But here, distal vessels are okay, but it's still good target from surgical point of view.
In the PDA.
And particularly the PDA. Okay, we can go back to the slides. So basically what we do in this particular case, although syntax score was moderate 26, but because of this such a significant left main, our protocol does include routine heart team discussion if syntax is more than 32. But this particular case, because of also moderate AS, it was felt to have a discussion with our surgeons, and actually Dr. Phil Sufi saw the patient yesterday, and the plan was to not to do CABG and may require also surgical AVR at this time because of moderate AS, and knowing that ongoing neurologic symptoms, neurologist said risk of stroke because of bilateral about 12 to 15%. So felt that do the PCI and then they do the carotid endarterectomy. So that was the plan after the heart team discussion. You agree with that? What do you say?
Well, I wasn't involved in that. I'm just meeting this patient today. Another option would be on a combined operative approach to the carotid and the CABG. The carotid could be done even under local anesthesia with monitoring, and the CABG could be done under general anesthesia with an off-pump approach for those two vessels. I think the combined stroke risk of that procedure would exceed 2%, but would be less than 5%. And I do agree with the neurosurgeon impression that if we did not treat that very tight symptomatic carotid stenosis, but simply did an on-pump CABG, the risk of stroke would be high, prohibitively high.
And if patient goes for surgery, you'll replace the valve also, even though gradient is only 15 and calcific, or no?
I think that's a great question. You know, 5 years ago, absolutely. 10 years ago, for sure. Now, probably not. I would probably prefer for this man to minimize his stroke risk in the first procedure, which would, in my mind, be a carotid endarterectomy and off-pump two-vessel bypass, and then do a TAVR at a later date, because his gradients are not high, and he's stable, apparently, for years with his known AS. So I think we could address his revascularization from a cerebral and coronary point of view at this go, and defer management of his aortic stenosis.
Okay. So, and Greg, particularly you with the imaging guru and so many, anything else more needed for in this particular case? I don't think we need to do FFR with such a 95% distal left main.
No, the left main's obviously critical, and to me, this would probably not have been an Excel patient. It qualifies anatomically for Excel, except because of the stroke risk. I think that would have been an exclusion. And to me, that's the risk of this case, is stroke. So I think with the heavy calcified left main actually involving the aorta, that's an increased risk for surgical stroke. So for that reason, I think PCI is probably safer in this case. And I think with an experienced interventionalist, doing the left main proximal LED is relatively straightforward for an experienced interventionalist. The circumflex, I agree, is a small vessel, not important. The difficult vessel is the right.
Right.
Because, I mean, it's really diseased from the ostium of the right all the way down to the crux. And then that mid PDA actually becomes atretic. So, but the patient's life is basically the left main and the proximal LED. And I think I agree to go ahead and fix that, in particular with PCI, image as appropriate. This maybe treat the proximal to mid right, let meds take all the distal right. We'll see what you want to do there. And then have the endarterectomy done. And then again, you can have a TAVR 2, 3, 5 years down the line when the aortic stenosis becomes severe. That's not an issue for today.
So, Samin, excellent discussion to start off. Greg, first of all, welcome to Mount Sinai.
Thank you.
Your addition has made this a cardiovascular powerhouse in the world.
Of course, yes.
John,
my pleasure.
John, your comments are right on, and here is a question straight for you to start off. And you kind of addressed it. Why not consider CABG, AVR, and CEA in the same setting, coming from Sammy123@AOL.com.
Well, that could certainly be done to do all three. But I think that the sum of the stroke risks from each of those procedures would be higher. And I think right now, with a symptomatic tight carotid stenosis and a scary, tight left main stenosis, our goal should be to revascularize the brain and the heart and avoid a stroke in the process.
Right.
The moderate aortic stenosis is not what is bringing this man to operative attention, and has been stable apparently over time. So I would prefer to try to get him through this revascularization procedure, combined by whichever way we ultimately go, and address his aortic valve. By the time he needs the aortic valve done, he will likely be in his 80s, and a TAVR would be a very, very good option for him.
Excellent.
Okay,
Completely agree.
Samir, yeah. So no, that's absolutely, we are going to go with the slide. So we continue this process, and our strategy today is IVUS guided high-risk PCI of calcified left main using rotational atherectomy because of that such a high calcium burden, and use just single crossover stent approach. That is our basically the plan, and we calculated both STS and syntax. With low STS score. I know the 5 has been kind of cut off in many of the studies, right? The STS 5 just makes it to the high risk case. And appropriateness, yes, it's a distal left main bifurcation, more than 22 syntax score, but have gone through a proper discussion, and based on that, decision has been made to go forward with the intervention at point and try to keep it minimal, that to use a single stent approach. And you had a discussion with the patient also?
Yeah. The patient as well as the referring doctor, who actually is a vascular surgeon.
Oh, the referring doctor is vascular surgeon, that's good.
I don't think too many people would question the appropriateness of this case.
Yeah. Okay.
I think once we have a long sheath, I mean, we initially did VL35, we have to go to a shorter sheath now. If need, it's a 45 centimeter long sheath, we may have to change it to 25. Let me see if I cannot engage.
Samin, a question for you. Would you have considered an impella here?
Yeah. So actually, you know what? I think that's a very good point. The case which we had Friday, earlier patient, we definitely had a plan for impella with a EF of 25%. This case actually, some new information just came this morning. We have echo about 2 months ago, AS 1.2, and ejection fraction 60%. They did echo last night. Now they're saying the valve area is actually 0.9 and gradient is still 20, mean gradient, but now saying ejection fraction is 45%. The patient has no clinical event in last 2 months, whether it's from AS progression or from just left main. I mean, it's a significant, I think this may just give rise to some ischemia.
It's possible.
Yeah,
it's
because
possible.
EKG is completely normal.
Short sheath.
Very tough to understand that this EF has gone down for any clinical MI, except maybe just ischemia for such a significant left main and RCA disease.
What was the velocity across the aortic valve?
The 2.6.
Oh, 2.6. Okay, so
But stroke volume
not,
index
not
was
significant
Yeah.
unless the cardiac output is way decreased.
So they say the stroke volume was 31, so it maybe fall into that category of stroke volume index of 30, that may be low flow, low gradient.
Right.
But this the patient.
I'd fix the left main first, and let's see what happens.
I have to change the sheath is too long, not allowing.
Okay, so while you're changing the sheath, we can go through our Excel
Start
trial
your discussion, and then-
discussion. And I know that John has to leave by 8:30. The surgical patient is ready. So we usually do as a part 2 topics of discussion, and then one today will be the Excel trial of left main revascularization, 5-year results, and then update on contrast nephropathy and the recently presented remedial 3 trial. So the left main issue, which is 5, Greg being the PI, the first author on this study, which we well know 3 years ago, data presented of about 1,800 patients showed, and now the follow-up of those patients, 90 plus year at the 5-year follow-up. And I'll just ask Greg to comment on one thing, and that is also, and this is very relevant, what site reported syntax score. Remember, entry criteria was syntax of less than 32 or so. But then at the core lab, almost 1/4 of patients had a syntax score of more than 33. And I'll come back to the discussion maybe later on, because remember the trial of future trial of FFR, guided. they actually had higher mortality, and then they found those subgroups who had higher mortality were the higher syntax score. So clearly 1-4, but this could not have been avoided, right, Greg? I mean, even if you have great operator.
Well, sites always underestimate the syntax score. So in syntax, it was about 20.5 was the mean syntax score by site estimation, and it was 26 in the surgical arm and 27 in the PCI arm, slightly different. I mean, even here, it might be a little bit higher than 26 when you really add everything up.
If you add LED, definitely will go up. Yeah.
Yes.
But the important thing is that, a quarter of the patients, as you said, in Excel had a high syntax score, but that's the kind of the low range of the high syntax scores. It's the ones the operators thought were intermediate, but they turned out to be a little bit high. Now, it is true that, the Excel outcomes were very similar with low, intermediate, and high syntax scores, but I don't think that means that we should generalize Excel to the very high syntax scores that everybody agrees should be managed by surgery if it's a surgically eligible patient.
And I'll ask you the specific question on this point a little later. And of course, the latest of the greatest technique, whether PCI or by the CABG, were done. IVUS guidance in majority of patients, and of course,
maybe FL guide.
Imaging assessment, hemodynamic where needed, and
FL,
from your point of view, John, you will say the surgical techniques were as good as could be, right?
Well, I think actually in Excel, on the whole, surgical technique was better than previous trials.
Any trial.
We have 24% of cases received double mammary grafting, and 24.8% received only arterial grafting. I would love for those numbers to be 2 or 3-fold that, but there's never been a trial that does that. I think there are only individual practices like our own that deliver arterial grafts to the large majority of coronary targets. So I think that within the context of multi-center trials, this is pretty good surgery.
Yeah. And Greg, knowing that majority of those patients had a distal left main disease, but yet majority got single stent,
right?
And that was before the data of the DK crush came up.
That's
right?
correct. Yeah. So I think the outcomes might have been a little bit better with more aggressive stent techniques in the distal left main, but overall the stent thrombosis rates were 1% at 5 years, definite stent thrombosis. So you can't get much better than that.
And people always ask, you are left main disease, and now we are truncating the depth duration. But it's an intuitive feeling of all interventionalists, cardiologists to continue prolonged depth, particularly in the left main. And see the data of yours at 5 years. So depth was continued almost in 62% of cases.
Yeah, but we have no evidence for that. And in fact, the left main is a large vessel. It's actually got a relatively low stent thrombosis rate. So I think the decision to continue DAPT should be conditioned on anatomy, but it's probably more the diffuse disease elsewhere. Did you put in another 50 millimeters of stents? Were there other bifurcation, 2-stent techniques, et cetera? So for a good technique, IVUS guided in the left main, I don't think that's a reason to prolong DAPT.
Okay. So this is the key slide with the outcomes. The primary outcomes were death, stroke, or MI. So that is very interesting. Remember, compared to syntax included revascularization also. So here are the slight difference in the beginning in favor of PCI, but at end 22 versus 19.2, and dead heat with the 1.19 odd ratio with the 0.13. Any surprises?
Yeah. So, so this curve actually looks very much like the ischemia curves, and a lot of the aggressive techniques, the more aggressive techniques we've kind of learned, have an upfront penalty, okay, in terms of arguably harm, but then a late benefit. And so here you see the curves cross, and the curves cross at about 2.5 years. And so this is what we call non-proportional hazards. So you actually have an early benefit of PCI, in particularly within the first 30 days. And it was really due to fewer large myocardial infarctions, less Q-wave myocardial infarctions, ST segment elevation, MIs. And here you go, the piecewise hazards. From 1 year to 12 months, 1 month to 12 months, there was absolutely no difference. And then beyond 1 year, CABG has a benefit, and the primary benefit was in the prevention of late myocardial infarctions. So how do you overall communicate to the patient these different risks? At the end of the day, there were no significant differences, but there's an upfront hazard to CABG, but then there's a late benefit to CABG. So you can look at the area in between the curves, and average that over time. And that's a new concept for many people. It's called the mean restricted survival time. And at the end of the day, the time event-free from one of these major events was almost identical at the end of 5 years between PCI and CABG. So I think when there's truly equipoise in terms of death, MI, large MI, and stroke, you get pretty similar outcomes at 5 years. But the curves are diverging, and it's possible that if we went out to 10 years, then there might be a modest benefit for CABG. But we don't know that. Unfortunately, our follow-up truncated at 5 years.
John, your perspective on this?
But I don't know whether you have, the all-cause mortality slide.
Yeah, we'll come back to that. Yeah, but overall, I mean, are you surprised with the results so far?
I agree with everything that Greg has said thus far. It's important to note that the curves do cross and that they continue to diverge over time. And I think what that tells us is that for patients with a limited life expectancy, PCI is clearly better. If you're going to live 3 or even 5 years, PCI is better. And especially if surgery would entail a big upfront risk of a adverse event like stroke for this patient, then you see that PCI has an early advantage without question. On the other hand, if that risk of stroke were not great and the life expectancy for the patient were extended, then I think CABG would offer a better long-term result. So I think that in general, we as cardiovascular professionals should be thinking about doing less PCI in young, relatively healthy patients. We should send them to surgery earlier. And we should be doing more PCI and less CABG in elderly, frail patients who may fit the criteria for CABG, but for whom the procedure is morbid up front and their life expectancy is relatively short.
No, I think that's your statement is resonate with many of us and many of the meetings that more CABG in young age, more PCI in old age probably is the right thing to do for the patients. So this is what the restricted mean survival time analysis you meant, right?
Right, yeah. Exactly. So the area in between the curve is really the burden of disease for these patients. That's you. And so again, when you average it out at the end of 5 years, PCI patients had 4 more days on average being event-free than CABG patients. Okay, despite the fact that the curves kind of ended a little bit lower, it's, you pay me now, you pay me later. So that's obviously a wash, no matter how you look at it at the end of 5 years. So you have to now consider other things beyond just these hard endpoints of death and MI or stroke, the less invasive nature, the earlier return to work, less AFib, less acute kidney injury, etc. But you've got, with CABG, you have less revascularization, you have less late myocardial infarctions, so you have to weigh all of these and importantly present the pros and cons to the patient. You've got stroke risk, we've got mortality we'll talk about in a minute, and then let the patient weigh in on what's important to them.
And then Samir, they see this consistently in all our interventional trial comparing to technique. Things happen after 3 years. Barry,
yeah,
syntax,
Okay.
freedom, 3 years looks good. But after 3 years, somehow PCI start losing, and now question will come back that why we start losing, and as we showed in the limited graph, after 1 year, maybe it is because of higher myocardial infarction at that time. So these are the individual endpoints. I just put it there for the purpose. So if we put together of syntax type of primary endpoint, these are the 1 year, 3 years and 5 years, you clearly see superiority of the CABG. If you incorporate ischemic driven revascularization, these are the 3-year endpoint. And this was a signal when I presented my data earlier, when Greg presented 2 years ago, the death of 8 and 5.8. Knowing that those things all happened after 3 years, we are just at that cusp with the 1.36. And of course now, we are at 5 years, and now you see here clear, while overall primary endpoints are similar, there are some numerical differences in MI and stroke. Ischemic revascularization is higher with the PCI. Stent thrombosis or graft occlusion favors PCI, but the mortality of 3.1%, which is really still the debate, that yes, primary endpoints are similar, but you have this very important endpoint in any trial, even if it was not a primary endpoint alone, favors coronary CABG. And this is where I think I need to, both of you, make a statement on this observation.
All right, so John, you get to go first.
Well, the mortality difference is obviously the most important thing. We could not power this study based solely on mortality, so of course a composite primary endpoint was used from the very beginning. Death obviously was a pre-specified secondary endpoint to be reported, and it has been reported, and it is different and divergingly so in favor of CABG, really beginning at about 2.5 years. So the 3-year data were clearly a wash with a signal for favoring CABG for death. But at 5 years, there's a pretty striking difference, and the mortality curves are diverging at 5 years. I think it's important to recognize that myocardial infarction has significance fundamentally in decreasing ejection fraction and driving mortality. So while CABG had a higher myocardial infarction rate in the perioperative period by the chemical definition chosen by the study group, that did not translate into more mortality in intermediate and longer term follow-up. So the direction of myocardial infarction and the direction of mortality are opposite. So in my mind, that makes the myocardial infarction a much less important component of the primary composite endpoint, and mortality remains the fundamental driver. And it gets back to my earlier statement. If the patient has a 1 to 5 year survival likelihood for other comorbidities or advanced age, frailty, etc., and PCI is the better option. If the patient has a 20-year opportunity to survive, then I think CABG is likely, especially performed with arterial grafts, likely to be the better option.
So let me tell you why I think it's almost for sure that this is a false positive. It's a red herring. It's not true. First of all, you notice that there's no significant difference in myocardial infarction. So why, and in fact, there tended to be less stroke. There were statistically less cerebrovascular events when you add them all up at the PCI arm compared to CABG, which of course contributes to mortality. So why should there be a difference in death? So when you look at cardiovascular death, which you would think would be, if there's going to be a difference between PCI and CABG and cardiovascular death, there was no significant difference. Almost all the difference was in non-cardiovascular death, especially due to late malignancies and late infections, which plausibly don't make any mechanistic sense. So when a trial is not powered for a relatively low event rate, you've got to look to say, is it a plausible finding? You can have type 1 error or type 2 error. Type 1 error meaning a false positive result. So we have, again, for lower frequency endpoints, we now have 4 randomized trials of DES versus PCI and left main disease, about 5,000 total randomized patients. And when you put all of these patients into a single database and you add it up, the mortalities after left main PCI versus CABG are almost identical. So this is almost for sure a false positive finding in my view.
I mean, this actually has been the part, as you know, and this is, you have follow-up data. So
Right.
this were nice conclusions from this, and that lead to this. Sparks accusation flyover conduct of the XL PCI versus CABG. Now, you clearly have stated in that any endpoints which were changed were not changed any intentionally in terms of myocardial infarction definition. I think that is one of the things which is going on at present.
You know, I think John and I agree. We have one delusional surgeon who has made some claims, and I will say delusional, who has made some claims about endpoints being changed and data being manipulated, and he was involved on the leadership, as was John. And this trial was designed by an equal number of interventionalists and cardiac surgeons. It's probably the most transparent trial that's ever been. The database is open to everybody. Nothing has changed, and this is a non-controversy by a disgruntled surgeon. I'm sorry, it's really nothing more than that.
I think you need
John.
to comment on this one, John, and then I'll ask Samir.
Well, you know, every definition of myocardial infarction has to be chosen, right? We have to have a definition in every trial, and this definition was known and chosen and utilized. You know, and I think that
And did not change.
debating the choice of the definition after the fact, you know, is an academic exercise. It should not be an aggressive exercise. Every composite primary endpoint is sensitive to the definition of MI. And indeed, if we were to eliminate perioperative MIs and only track MIs after, say, 1 week or 1 month, the composite primary endpoint would look very different. And I would argue that, just getting back to Greg's earlier comment about, look, there's not a difference in myocardial infarction at 5 years, so how can death be real? And I would argue that the reason for that is that the perioperative MI definition tagged cardiac surgery with a lot of MIs that weren't clinically important.
But that's not true, John.
But wait. So that then the later MIs are the ones that are important because they represent either graft failure or stent failure or progression of native disease with new acute MIs, and those limit life. And so I think the benefit of CABG, and this is a concept I think is important, is that it creates a surgical collateral. And it protects against future myocardial infarction at the price of upfront myocardial infarction by some, in fact, many definitions. Enzyme leak, especially in on-pump cases, that is measurable and demonstrable and evident. But the later MIs are the ones that seem to kill. And I think that the benefit of coronary bypass surgery, frankly, is that we bypass the first half or 2/3 of the vessel. And any future lesion that develops or ruptures or thromboses in the proximal half or 2/3 of the vessel is unlikely to cause mortality or even MI because of the presence of that surgical collateral that protects the distal circulation. That's the fundamental difference between PCI and CABG. CABG protects against present and future lesions upstream of the graft. PCI deals with flow-limiting lesions in the proximal portion that are stented. And both have great advantages for different patients. Some of them overlap and have advantage for similar patients, and they both have an important role to play in cardiovascular care.
So let me just correct one thing that John said, and I agree with almost everything he said. However, these are not just enzyme leaks, these periprocedural infarcts, because we excluded those. We only agreed as a committee to include large myocardial infarctions, CKMB greater than 10 times the upper limits of normal. These have been associated with large imaging defects and wall motion abnormalities. And in fact, if you looked at, and we published this in the European Heart Journal, the impact of periprocedural MIs as defined in Excel by multivariable analysis, there was a 3 times increased risk of mortality out to 3 years and now out to 5 years that applied to both those, that same definition after PCI and CABG. So these infarcts did matter. Now we also looked at the impact of smaller infarcts, smaller elevations, and those did not matter. Okay, and this is all published in the European Heart Journal, and you're an author on the paper, as is the disgruntled surgeon. Now, where I do agree with you is that the late myocardial infarctions, I think, is real, and we've seen that in every single trial, and I do suspect it is because bypass surgery does bypass so-called vulnerable plaques. Atherosclerosis, where the plaques look like they're 30% on the angiogram, we don't treat them, but they're probably lipid-rich, they're thin-cap fibroatheromas, and they do go on to rupture, cause myocardial infarctions, and that is one of the benefits of late surgery.
And those plaques are more vulnerable in the diabetic metabolism.
Absolutely.
And this is why I think we see a bigger divergence in relative benefit of CABG and PCI in the diabetic population. I think it has to do with the activity of the proximal lesions in that population of patients.
So there's a lot to discuss. Last thing about diabetes. In Excel, diabetes was not a risk factor. In syntax, diabetes was not a risk factor. So what actually is more important than diabetes is the extent of atherosclerosis. And if you have small diffusely diseased vessels, as diabetics often get, those are the ones that are really going to do better with CABG than PCI.
You know, just so the listeners understand, it's not that diabetes doesn't matter. It's that diabetes matters by causing diffuse disease.
Exactly.
And if you say, oh, we're going to correct for diffuse disease, then diabetes in and of itself doesn't matter.
So you take a few nice focal lesions, PCI does great in a diabetic.
And coming back to the point, and this turns out to be the same, the left main, now we have the 10-year data published in Lancet, presented a few years ago, that difference in 3 vessels, same. It's an extent of atherosclerosis which kills it. It's the left main large vessel, and then here, even with the individual syntax score didn't make difference, although a small number. But it is the multi-vessel disease and high syntax score.
You saw the left main. The left main, the point estimate for 10-year mortality even slightly favored PCI. So you can't just cherry pick one number from one trial. You have to look at the totality of the data in making these decisions.
And it's probably true that the left main artery itself, being short and large in caliber, should be an ideal setting for a stent. The long, small caliber vessel would be presumably more likely to be a challenge for percutaneous technologies. The short, wider caliber vessel ought to be the better situation for a stent. It just, by logic, it seems to fit. So I think that in the end, focal left main disease will be a percutaneous disease, and multi-vessel diffuse disease will be a surgical disease, at least with present available technologies.
So, and that's why I said in this case, the left main doesn't bother me so much. The right coronary.
Yeah, it's the right and the proximal LED. So is this two-vessel disease with left main, and what are we going to do for this man's right coronary? We could fix his carotid and fix his left main, and he could arrest from a sudden occlusion of one of the plaques in his right coronary.
Right.
But we'll try to fix that
6 months from now.
and hopefully this ongoing little difference in USA versus Europe in terms of guidelines might change with the 5-year data, may not change, I don't know, right? But I think we are ready to go with the, we have spoken quite a bit. Anu, you want to tell us, took us a little time, what happened today with those so many guides?
Actually,
You go on the
we can show
camera here.
some the ceiling camera just to show the amount of the guides that we have used. Yeah. So the reason maybe because he had a small aorta, and this one other thing I think, which other thing that we normally face with a lot of discussion going on, who should be going for CABG, the age. What is the age cutoff you think, John, for us? If we think somebody with the high syntax score. Our discussion is, younger patients should be going for CABG.
Multi-arterial CABG, yeah.
Yes,
I don't blame the interventionalist who, faced with a choice between 3 stents and a lima and 2 veins, chooses the 3 stents. I think the interventionalist should be demanding more arterial grafting. Yeah, that's a preface to try to answer your question. I think that in terms of age cutoffs, it's very difficult to state that. It really has to do with physiologic age. Patient's own expectation for life and activity. The patient whose life consists of watching television and getting to the bathroom and the refrigerator doesn't need full revascularization, just needs a culprit lesion treated. The patient who is 60 years old and still working will benefit from multivessel arterial revascularization.
So how do you respond with Dr. Taggart's ART trial, where bilateral IMAs didn't make any long-term mortality difference?
I think that trial was, a very, very flawed trial, because there was an unfortunate crossover between those groups. About 14% of patients who were assigned to the 2 mammary group actually received 1 mammary. And 22% of patients who were assigned to the single mammary group received a single mammary plus a radial artery. So in some, almost 40% of patients who were supposed to get 1 artery or 2 arteries got the opposite. And that has, I think, led to an intention to treat analysis that is largely a wash. But if you do sort of a post hoc as treated analysis, and I put that in quotations because it's 1 artery or more than 1 artery, where more than 1 artery is commonly a radial artery added, then there's a striking survival benefit in favor of more than 1 artery. But that is a post hoc analysis and not pre-specified.
So it's easier to do surgery or PCI compared to running a good trial.
I think yes, I would argue that that's clearly true. And it turns out that doing double mammary grafting was harder for the surgeons in that group to do than was anticipated. All were stated to have been experts before they started, and yet some had a 50% crossover from assigned 2 arteries to 1 artery.
And I can tell you, from system point of view, that I'm a big proponent of arterial grafts, and knowing that same, but in the trial, like in teens, you get a double arterial grafts at Sinai, and selectively I sent cases to John at St. Luke's. Patients are very, very happy with your service, of course, always were. In the past was a little infrastructure issue, but that actually seems to be no trouble now. So I sent a lot of patients from here to St. Luke's. To John to do a great job, and I've been extremely, extremely satisfied with this arterial. I'm a big believer of that. Big believer.
But if we are a believer of arterial graft, right, John? For us, I think the surgeons who can technically do that kind of artwork like you do are very few in the country.
That's true. And that's
so for us as interventionalists to be convinced a young patient, I think if a lima is given to the young patient, should get it for 25 years, then you need an artistic surgeon,
Yes,
That's true.
Yeah.
it's a fair
which,
statement.
which is rare, and that's why I think the
In
intervention
fairness,
is
I think
phased.
it's also true that not
PCI?
all PCI teams can do what you
Yeah.
and Dr. Sharma do on a daily basis, and on a live webcast in particular. Unfortunately, what we all do is operator dependent, and there is a spectrum of ability and experience, and as a result, patient outcomes are different in different facilities.
And that
knowing-
has to be
yeah.
taken into account. The local expertise relative of
Absolutely.
intervention versus surgery has to be considered in these decisions.
Absolutely.
Okay.
Samin,
Yeah.
absolutely fantastic free flow discussions in a most professional and collegiate atmosphere by Greg and John. I felt it would be absolutely irresponsible for me to interrupt that. I want to thank both of them. We cannot control the sparks and the accusations, but I can tell you this is exactly the right way to deal with it. And to me, the entire emphasis coming out of the Excel trial, and John and Greg, feel free to comment on what I am going to state, is the absolute and critical importance of the heart team.
I agree with
Yeah,
that.
we both
100%.
agree.
This has to be a conversation, patient by patient, with the best information available, and it should include the patient.
Now, John
Absolutely.
and Greg, I've had a flurry of questions directed to both of you. I'm going to ask them for some very quick responses. Can the discussants comment on if there was a landmark analysis after, say, 30 days measuring the incidence of MI in each arm of Excel as a potential explanation for the 5-year mortality difference?
Well,
So-
we see that. You see, after 1
Yeah.
year, for instance, that we looked at the primary composite endpoint from 30 days to 1 year, and then from 1 year further on.
Yeah.
And you can see that it's in favor of PCI in the first 30 days, and in favor of CABG after 1 year, and kind of a wash between 1 month and 1 year.
But we did that analysis, and the MIs do not explain the mortality difference in Excel. The MIs have a relatively low attributable risk to the number of deaths, and most of those late deaths and the differences were due to non-cardiovascular causes. They were due to cancer, they were due to infections, things that myocardial infarction had no relationship to. So again, that's why I'm very confident that it's a false positive.
So I'm
My
going
only-
to gently disagree with Greg. I think adjudicated death is a lot of smoke and mirrors in a lot of trials through history, and that the one thing we can count with complete certainty is how many patients are dead at the time of follow-up.
Right.
Whether they show up in the emergency room dead on arrival, and get scored for myocardial infarction or not is
No,
is a
that would
different
be
thing
called
to-
a cardiovascular death. It's actually not that hard. People fall back on saying, oh, it's so hard to adjudicate death. When you see somebody's got disseminated metastatic cancer and then they come in dying of that, or if somebody has urosepsis and they come in dying
Put
of
the
that, it's not
bookmark.
so hard to adjudicate it. Yes, you may get a misclassification of a couple deaths here and there, but we have to have you attend some of
Mr.
the
Left
CEC
main.
meetings. You'll find out it's
Okay.
not so hard.
But a patient who's got an in-stent restenosis or a failing Lima graft, who gets septic from urosepsis, may fibrillate
Bookmark.
at home, and they die with urosepsis of an MI. But in the end, they're dead. And I think the one thing we know is that they're dead.
John, let me take you through. I want to accommodate
Let me
as
just
many.
ask the one
Yeah.
question, because we have
Go
to
ahead,
ask
go
John
ahead.
because he has to leave soon from
He can wait.
to the he has surgery. Now, Mike, just to complete on this death issue, could it be that the deaths which we have in the PCI group are the high syntax? Has anybody looked into it?
Yeah, we did, and they
I see.
weren't.
Were not.
They,
Okay.
they weren't. It wasn't related to syntax
Yeah,
score. And again, we have 4 other trials,
Yeah.
and you have 10-year follow-up for syntaxes, and none of them show increased death with left main PCI. So I really think this is most likely a false positive. For low-frequency endpoints, you have to look at the totality of the data.
Okay, question for John now.
Yeah, more.
Mr. Mishra.
John, maybe you should address this before you leave. Was high degree left main stenosis associated with worst outcomes after CABG in Excel? Left main occlusion after CABG is often associated with the worst outcome. No? I'm
Yeah, I
reading
think
the
those-
question as it is, so
Yeah,
don't blame me.
Right. No blame here. It's a conversation among colleagues. Left main disease does in general have a slightly higher perioperative mortality and morbidity than non-left main disease for surgery. And within XL, Greg, help me now, did the percent stenosis of the left main impact mortality in the CABG group? I don't know the answer to that question.
I don't
Got
think we've ever looked at
Stand
that.
across?
I don't recall an
I
analysis
don't
of
think
that.
we've looked at that.
The balloon first.
Not in perioperative
It's
mortality.
an
or
interesting question. We
complications.
should look at it.
Yeah, we could.
That'd
We
be
certainly
an easy thing
could.
to do. Because
Would you expect it to?
well,
I mean, as soon as you go on bypass, you know, why
doesn't
would it matter?
It could be that antegrade cardioplegia is less well
Yeah.
delivered, that myocardial protection might be less effective. Maybe tighter left mains have more calcification in the ascending aorta, they get more
Maybe.
stroke. But
Maybe.
it would be an easy thing to do
Sure.
an analysis of.
Sure, we can
And
definitely do
could
that.
produce a publication for the surgical literature.
Sure.
Samin,
It's a good idea.
most of the other questions are for you and for Anu. So,
And all has been
John,
discussed anyway. This has been a tremendous.
absolutely, John. Thank you for enlightening us. Your comments are absolutely fair and
He
balanced.
doesn't want to leave.
Okay, good.
He wants to watch.
More fun than actually working.
Samin,
I'm
Don't
going to
let
do
him-
something
don't
we do
send
every
him
day.
out.
We've got
Yeah.
3 cases
Yeah.
with,
Please.
we'll probably do 10 arterial grafts in those 3 cases. But I've never seen this rotoblader activity that Anu's doing now.
Notice how
It makes me
wonderful.
think of the Channel when they dug the train under the English Channel and drilled a hole through, and they got this great big pipe, because that looks like a great big pipe now.
Yeah.
But notice how stable this patient was. There was no hypotension. It's a very slow, steady technique. You do short runs. You allow antegrade perfusion in between the runs. So people
That's all
think
the-
that there's a need for
That's it.
hemodynamic support in a lot of these left main
What's the
cases,
difference
especially with
between-
atherectomy. And in
What's the
Excel, it
difference
was
with
used in about 2% of cases. And as long as the left ventricular ejection fraction is preserved and the patient's not hypotensive or with high filling pressures at baseline, usually you do not need hemodynamic support. You always have to be ready in case a complication develops, but usually you don't need it.
Well, in this case,
And
in
then get
particular,
me a
maintaining
3-5
good
high pressure-
hemodynamic stability is important for stroke risk, because he has
Absolutely.
symptomatic, very,
Absolutely.
very high-grade carotid stenosis. So we've been watching that. The monitor's been remarkably stable.
Yeah.
And what happened is our nursing staff is very well tuned. They have a dilution of the neosynephrine.
Right.
They see the blood pressure less than 100 in double digit, they'll automatically give you any neo so far?
Yeah.
1. So they will automatic. It's all protocol.
And that's
Anytime you're
maintaining
doing your
cerebral perfusion to
systolic
the
pressure
patient
has to be in
throughout.
triple digits.
Yeah, lovely.
So they'll automatically will give it.
Greg, question for you here. In this high-risk patient, is carotid stenting not possible?
No, it was not. It was a surgical decision, and the interventionist very calcific. So remember, calcific carotids, the interventionists don't do it. It's trouble.
Right.
They all go for carotid and arterectomy.
So
That
that is
is no-
that's the
That's-
answer for you,
that's the
Dr.
answer.
Jain.
Yeah.
But it would have, if it for the right anatomy, then that would certainly be possible.
Okay, all right.
Yeah,
So
absolutely.
calcification here is the clue to
If
that.
this had been a fibrous carotid
Right.
Some
lesion
guy.
rather than a calcified eccentric plaque, carotid stenting in combination with this procedure
Right,
would have
this would
been
be
a
very
viable
nice one,
option.
yeah.
We should have discussed.
Greg, stenting across with the single stent the right approach?
You know, I think if the ostium of the circ is not involved,
Right.
and there's not a lot of distal circ disease where you're going to have to access the circumflex a lot either today or in the future, then I think in general it is. But I think we should have a lower threshold than in the past for a plan 2 stent technique. In particular, if there's a greater than 50% stenosis of the ostial circ, if it's a long circumflex disease, multifocal circ disease, or if it's very angulated to get into the circumflex, so you want that access. But in this case, it seemed like the circ's relatively small. It's primarily in the AV groove with a small distal posterolateral branch. And I think a crossover technique is the right way to go.
And that is what your paper sub-analysis by David Kanjari
Right,
was.
exactly.
That if you have a distal left main, both vessels are involved, that's where the real benefit of the 2 stent strategy.
Right.
So there actually 1 stent strategy is not right, because that's what comes back
Exactly.
with the problem. So if there is no disease just across like we have done in this particular case, patient has a lot of other disease, which is okay. But IVUS has been done. ostium of the
I can show
circumflex
you
was
the
fine.
Ibis.
And,
Yes.
and that's important. This is done with Ibis.
Yeah.
Thanks so much, John.
John,
This is done
thank
with
you
Ibis.
so much.
Yeah.
And if you're going to do complex left main cases, you should routinely be using intravascular imaging. Intravascular ultrasound, especially if there's ostial involvement of left main, or OCT for distal left main involvement. But it's really critical to optimize stent dimensions to make sure you don't have residual edge disease or dissections, because this is not where you can make a mistake in the left main.
Greg, a question from a Dr. Altir, a straightforward issue. Do you stop DAPT for endarterectomy?
Do you stop DAPT for endart? Well, that depends on the surgeon, but in general, I would say no. You know, again, aspirin and clopidogrel is all this patient's going to need, and you would not stop that for the endarterectomy.
All right. That's the answer for you, Dr. Altir. Greg, I was planning not to address the ischemia trial, but there is a question and it's directed to you from a Dr. Gursevak. Dr. Stone, what do you think about this patient in the era of the ischemic trial?
Sure. Well, this patient would certainly have been excluded from the ischemia trial because of the left main disease, as well as the neurologic disease. But say the patient did not have moderate aortic stenosis, did not have carotid disease, and had class 2 angina that could be controlled on medications. Then the ischemia trial said do a CAT scan to rule out left main disease. And the CAT scan in this case would have shown left main disease, so the patient would have ended up in the cath lab and have this procedure. Not many people would think you can leave a high-grade left main lesion alone without revascularizing it, although there are a few people who think that. Now, if the patient didn't have left main disease, if the CT scan showed everything else that's present here, the LAD, the circ in the right, and he had mild angina, then he would have been a good, an appropriate ischemia patient that you could have treated conservatively, depending on the patient's wishes.
Okay, AK, tell us about your so far the feat you have achieved in this particular case.
Case
Before
is
you go
done.
to the IVUS, yeah.
Slight damping of the catheter there. I don't know.
Always
Faster than-
mild left
Noticing
main,
some
yeah.
ventricularization.
Yeah, that's so I did. Let me tell you, I think the biggest challenge here when the discussion was going on, where are all the guides that I had?
Yeah.
That getting a guide, and this may be also that the discussion which we wanted to say in this kind of cases, elderly patients where we know there's calcific disease. What we have seen is calcific left main. There is calcium in the ostium of the right. Definitely there will be calcium in the aorta, and this is not uncommon for the surgeons. They do all the workup and then they come back to us saying that they cannot cross clamp the aorta. If you see, I can let it run.
And that's why the stroke rates are higher in left main disease, because of
So,
calcification in the aorta.
if you see here, these are the kind of cases that have come back to us. This is saying that they can calcific aorta, they cannot cross clamp. Can you do PCI on these patients? Now, what was the technical challenge on this patient? If you see, the root was small, so the usual that we went with a 45 centimeter long sheath, but then our VL35, if you can start showing here, give me a blue towel. I'm going to show you the guide choice that we went through, and finally what's the guide that finally, this is the usual that we use, VL35, which would not fit in this patient. So then, since if you see here, this was a VL35, how, I mean, it's a teaching point for the fellows. If the guide is facing down, then you know the guide is larger, you need a smaller guide. So we did try VL3, but then I think at some stage, the way the left main was coming off, I thought maybe a FCL curve may be better. This is the FCL curve, 3.5, still would not guide. Now we have what for the radial cases, that since we are doing radial, you need a smaller guide. So we have this made by Cordis. Those were made by Boston Scientific, the Mark guides. This is a same curve, okay, EBU curve, but it's like a VL. This is 275, shorter. But even the the 275 was large. The final guide that we got was EBO 2.5. Show it to them. What was the guide that finally sat there?
So these are the more for radial, yeah, and now used in this case, yes.
Anu,
So there was the FL guide.
Teaching point here is straightforward. If there are institutions in the era of having a a single manufacturer supply and all the silly reasons how decisions are made to finance a cath lab. I think when you're doing these complex cases, it's good to have an array of diffuse different equipment and be familiar with it. Like you pointed out, without the right guide, this case would have been a horrible struggle. Exceptional
And
case,
you
Anu,
see
very
there?
nice handling. There is one more before I let you answer that. Greg, Anu and Samin have previously answered this question, so I might as well have your opinion. Here is a question: timing of PCI and TAVR in patients with CAD and aortic stenosis.
No, all
Yeah.
depends.
So I mean, it really depends on the severity of the coronary artery disease compared to the severity of the aortic stenosis, the origin of the left main and the right coronary. Are you likely to impinge with the aortic bioprosthesis? I think there's more and more of a trend to actually do them together, and I think that can be very reasonable. In general, you probably want to do the coronaries first. Because you can have access difficulties once the TAVR is in place, but I think you've got to look at it on an individualized one-by-one basis.
Superb. Anu, what were you stating and describe to us the IVUS findings too?
Okay. Now
Yeah,
this
let's
is
see the
a
IVUS
post.
here.
Excellent apposition.
Yeah, well
No?
opposed. Yeah. Nice.
Yeah.
And there is
Greg,
a nice
you're happy?
ostial circ still remains.
Yeah, so I'm less interested in apposition than I am the actual minimal
Ostial.
stent area.
Right.
So,
Okay. Get us a
apposition
MLA.
with a large stent area has actually not been shown to be important, although it's so easy with intravascular imaging, to focus on apposition. So that looks very well expanded. We'd like to, make measurements to see exactly what it is, but it
Right
looks
there.
very good.
Okay, give us that's a circ.
That looks good.
This is after a 3.5 at 18. That's the circ area.
Yeah. Yeah, go to the left main. Yeah. Yeah.
Okay.
Greg, you were attending the AHA?
Good, no?
I was. We presented. I was one of the co-PIs of Ischemia,
Yeah.
and so that
Yeah.
was an all-encompassing experience.
Tell me,
So,
I'm going to
all-
change gears for ischemia,
You want to
leave
go
it
down?
for the December session. What did you think about the colchicine study post-MI?
I thought that was a fascinating study. The
Right.
Colcott study showed a 23% reduction
Is there something there?
in overall MACE events when used with a recent myocardial
Yulia,
infarction.
looks okay?
A lot of it was repeat revascularization, repeat hospital,ization, but the trends for reduction in mortality were present as well.
No. Don't
There was
pull
a
it out.
slight
Guide may come
increase
out. It
in
was like
pneumonia from
half hour to get the
0.4% to
guiding.
0.9%, so this is an anti-inflammatory agent, but still that's a relatively small increase. So I think it really proves the inflammatory hypothesis that was suggested with canakinumab in the CANTOS trial. And I
Looks
think
okay.
that there is certainly a role potential
post.
for colchicine now in the post-MI patient. It's very inexpensive. In general, it's well tolerated. Some people get nausea and dyspepsia from it, so you have to individualize that. But it's another drug to consider, especially for the patient with polyvascular disease.
No doubt there would be other anti-inflammatory agents
Oh, yeah.
in the waiting too.
Well, we have to develop more expensive ones. We
Yeah.
can't have just an inexpensive one.
That would break the
Okay.
trend we've established. Huh?
What else? And
No, I just want to give some vasodilators, little spasm in the mid LAD area,
Yeah, it
just
looks
distal
like,
to the stent.
that was
I
a
want to
myocardial
give-
bridge also there.
Yeah.
Did
The-
had you
no, I just
interrogated
wanted
that with
to
the
show you
IVUS
the
too?
pre-IVUS. I can show you the pre-IVUS. There was a question. I know there's a little damping of the ostial left main, but the area that was, shows the pre-IVUS there. Yeah, was 6.9 at the proximal part. So we know that area. That's why we our stent length was 23 millimeter, left main to prox LAD at the level of the first septal.
Yeah, but most of the people will bring that stent up to the ostium. Because they say you're not, as long as it doesn't protrude, you're not
Right.
losing anything. Because those patients come back with ostial disease.
And that'd be reasonable. You've got to be then very careful when you engage in the future with the guide that you don't
And the
get
tower.
longitudinal deformation. But it certainly would have been reasonable.
Oh.
But
But that's good.
6.9 is not a hemodynamically limiting area.
Good.
Greg, changing gears totally towards the approach, you think people
Yes,
are
most of them.
missing out
How
on
many people will
a
do a case
valuable
like this?
aspect
What
of
are you talking? I
atherectomy
don't
by
understand.
using orbital hair?
When you say missing out, I think orbital atherectomy it was certainly an alternative, and it could have been used here.
Right.
And we really need, ultimately head-to-head studies
Eventual
to
comparative,
find
yeah.
out what the risks and benefits and long-term outcomes of orbital is compared to
So-
rotational, and then in the future, intravascular lithotripsy, which is shockwave.
Right. More options coming up, and hopefully we'll get
Right.
a far better understanding as to their respective usage.
So what was
I
our
know
area
those-
in the left
Right.
main
Okay.
by Ibis? What was our minimal stent area in the
The
left
left
main?
main. I thought you
9
point.
left main. 8.5.
8.5. So not bad. That's acceptable.
Yeah. This is after 3.5 at 18
Yeah.
post.
Okay, so now I think I just finish it very quickly. Our other last topic, that is more so for, then the latest data of the DK crash. Now we have 3-year data, similar
Right.
to same extension of the continued benefit, and more so in the more complex lesions. So now second was on contrast-induced AKI, and very nice paper in JACC intervention about various strategies to improve. What can you do? More important, reduce contrast volume. And that really interested me, that we have so many of the new softwares with a dynamic coronary roadmap, metallic road mapping, and we actually have this. Anu doesn't use that, but clearly that you don't need to give dye, and just do the coronary based on that, and of course the stent boost is zero contrast and Dextran based OCT. And I needed to hear from Greg, where are we on that Dextran based they're talking about?
Yeah, I mean, you can do it, and you get slightly different dimensions. So there are correction factors to adjust for that. The image there's be somewhat more artifacts. The image is not quite as stellar, but you can do it. And certainly in a patient with creatinine clearance of less than 30 ml per minute, it should be considered.
So they put it together in a nice central figure. This is so helpful, putting all in the paper together, that what we should do for overall reduction of the contrast. And sparing, basically, they use a small, one of the things very commonly when they say, let me see, little flush injection. Right. I can tell you, total flush injection adds more than the true angiographic contrast volume. And so there's another nice review. Remedial trial was the renal guard with a high flow compared against the Poseidon data of the LVEF guided hydration. This actually guard system is available, and remedial 2 was beneficial, and then now the remedial 3 overall AKI and pulmonary edema basically showed that you give more volume by giving this fourth diuresis. Actually, I've been practicing this for a long time, giving diuresis in the end, and of course that led to overall lower primary endpoint with the ultrafiltration group, and compared to and then of course lower AKI, lower pulmonary edema compared to EDP guided group. So another, I would say, different lower major event. Now, another review article on this contrast, acute kidney injury by Roxana Maran. Really goes through the mechanisms and strategy of the high risk and low risk. So really this field is evolving quite rapidly. So just to sum it up, since we are beyond the time, Excel trial, as I mentioned, the landmark study, which really shows that in low to intermediate risk group, a similar outcome, but this death issue will continue to haunt us. But as Greg pointed out, it may be just a false positive, but we need to be careful about it. And maybe some additional analysis of those death patients will give us some light into as to the mechanism why this happened. It seems to be it didn't happen because of stent thrombosis. It looks like it didn't happen because of myocardial infarction. There's some other mechanism which we don't really understand. And the effective strategy of the contrast is innovative procedural technique, of using a decreased contrast volume, and secondly, hydration, and more importantly, the forced diuresis. Coming back to our three questions, the 5-year results of Excel trial of PCI versus CABG of the following except, means what is wrong? Similar primary endpoint of death, MI, and stroke, higher TLR in the PCI group, similar stroke rates between two groups, similar death rate between two groups, and similar MI rate between two groups. So based on the trial data, we know there was a higher mortality in the PCI group. Second, based on the Excel trial, following conclusions are true, except trial compared PCI versus CABG. Majority of the left main lesions were distal disease. Two-stent technique was more commonly used. About 25% of patients had syntax score about 32, and there was lower stent thrombosis versus graft failure. So only wrong is that single stent was used rather than two-stent technique. And the last question, following are the suggested strategy to reduce contrast-induced AKI, aggressive IV hydration, use of high-dose diuretics, IV hydration based on LVEDP, avoid nephrotoxic drugs, cath and simple PCI at same setting rather than stage 2 to 3 days later. So a lot of people do, well, I'll do the stage 2 days later, but that's a bad thing. You have more trauma to the kidney. So key is you can use diuretic, but diuretic has to be with the hydration. So alone diuretic, you remember the studies have shown that they are not good, rather harmful in the patient with the AKI. With that note, Samir, we conclude our today's fantastic webcast, very educational, and hopefully our viewers learned from this lively discussion. And I'm actually personally enjoyed it and took a lot of notes and for my further discussion in the community.
Samin, first of all, Anu, excellent case, beautifully performed rotablation and stenting, and good teaching tips about the guiding catheter. To our guest today, Greg, with you there, as well as John, you did an absolutely outstanding job tackling some extremely difficult issues which really should never have reached the controversial and flare-up points which they did. Your approach, your recommendations, your discussions were absolutely balanced, and we concur with almost all of your observations, and again welcome you to Mount Sinai. Finally, I want to thank our viewers today. For a moment they were dormant and suddenly they have resurfaced with intelligent and beautiful questions. With those words, we'll end the transmission today and see you for the next session on December the 17th.